Welcome back, everybody, and welcome to the next session. My name is Swapna Mandal. I'm a respiratory consultant who worked with my colleagues to look after patients in the acute post-COVID clinic in our local hospital. It gives me great pleasure to introduce Professor Trish Greenhalgh, who is a Professor of Primary Care Health Sciences. She's led a programme of research at the interface between social sciences, medicine, and working across both primary and secondary care. She has three particular interests, and that includes health needs and the illness narratives of minority and disadvantaged groups, the introduction of technology-based innovations into healthcare, and complex links, including philosophical and empirical, between research, policy, and practice. She was awarded an OBE for her services to medicine in 2021, and also made a Fellow of the United States National Academy of Medicine for her major contributions to the study of innovation and knowledge translation and work to raise a profile of qualitative social sciences.
So this is about, it's not my diagram, it's borrowed from, can't remember where now, it's very widely used, and these T0, T1, T2, T3 and T4 translations, so the T stands for translation. If we start on the left-hand side with basic science, that's where I did my first PhD. It was in a laboratory with test tubes and that kind of thing. And as you all know, there's a lot of laboratory type research needed in long COVID. There's a lot being done. And then the question is, well, how does that translate to humans? You all know that there's potential drugs that might be effective, but they may look good in the test tube, but do they work in humans? And the first thing that happens is those potential treatments get tested on non-patients, on humans, or the first thing that happens is they get tested on animals. And then if that goes okay, nothing terrible happens, they get translated to patients, usually in randomized controlled trials. But again, as you probably all know, the translation from the result of a randomized controlled trial to what's going on in the clinic is not guaranteed. And it's that link between T2 and T3 translation into practice, and also the T4 translation to populations. In other words, it might happen in one clinic somewhere in the country, and word gets around they're actually doing this, but it doesn't happen anywhere else. And that's where we get T4 translation, or the questions around T4. Why is it so hard to get something that works in one place to work more widely? So it's the T3 and T4 translations I'm going to be mainly talking about. Now, when I'm in the locomotion study, you've heard from other people this morning about the locomotion study, and we've got about 10 long COVID clinics in it. And the bit that I was running was implementing evidence in the clinics, or that the research that I was doing. I wasn't running the clinics, and that's important. So this rather confusing diagram represents the original plan. So the idea is you've got some evidence about what works, and we're going to set up something called a Quality Improvement Collaborative, or QIC. And the first thing you do, that pre-work thing, is that you set some goals for how you're going to improve practice based on evidence, and then you prepare for a learning session. And in a learning session, these days they happen online. Everybody puts aside a Friday afternoon, joins in the learning session, and they do something called a PDSA cycle, plan, do, study, act. In other words, they get their heads around, what is it that we need to implement? What is the evidence-based practice? How are we going to do it? But also, how are we currently performing? Let's have an honest sharing of our audits, if you like, and then think, well, actually, we're not doing great. Can we improve what we're doing, go off and collect data, and then 6 weeks later, come back to the second learning session, and hopefully things will have improved. And we document all that. And so you get these continuous learning cycles. But also in a quality improvement collaborative, people or clinics who are not doing so well in one area of practice can learn from models of good practice elsewhere. Well, that was quite a good idea. I think they gave us some money to have a look at it. So we set up a quality improvement collaborative, and it didn't go too well. We tried to establish the QIC, we got people signed up, we got clinical research fellows coming along every few weeks on the Friday afternoon, but the meetings didn't go well. People didn't bring much data, or when they brought data, there were arguments and questions around what the data meant. And also, as you can imagine, around the evidence base. So some clinics were running on one set of evidence, and other clinics were running on another set of evidence, et cetera, et cetera. And if you look, I was sort of interested to see why our Quality Improvement Collaborative, particularly in long COVID, we struggled with it. And I've run Quality Improvement Collaboratives in other conditions, and frankly, they're a whole lot easier. So these are the known success factors for any Quality Improvement Collaborative. And the top one, maybe will bring a smile to your eyes: clear and uncontested evidence base. And we all know that people are really arguing a lot about what the evidence base is. In fact, arguing about what long COVID is, what causes it, what are the treatments, who should be investigated, topics and goals that align with organizations' priorities. This is quite an interesting one, because different long COVID clinics are run by different departments. Some of them started off as respiratory follow-up clinics of people who were on ICU on a ventilator, for example. Some of them are very much rehab clinics, and they're set up by rehab teams. One long COVID clinic I know is an adaptation of a pain clinic. So there's lots of different logics that's driving what happens in those clinics. Another key success factor for quality improvement collaboratives is wide engagement from within the team, and not just the people who come to the meetings. And I think in our QIC in locomotion, people came along, and they were the people who were being paid from the locomotion study. But sometimes those people didn't have a lot of power in the organizations and in the clinics. The clinics were running the way they wanted to run, and they weren't all that interested in what was going on in those QIC meetings on Friday afternoons. Organization level support: if you want to do anything in an organization, the CEO's got to endorse it and back it and drive it. We did have protected staff time, but perhaps not enough. We did train people in specific quality improvement techniques, such as Plan, Do, Study, Act. Perhaps we didn't train them hard enough or intensively enough. Perhaps we should have actually gone out to the clinics rather than doing it online. Attending to the human dimension, there was some interesting stuff came up when we audited one clinic about how much the clinicians, the frontline clinicians, trusted the research team, and how suspicious people were of us being there. We needed good data on both the process of care and the outcomes of care. And there were problems with that in these new and very heavily attended clinics where, as I'm sure you know, it's hard to get an appointment in a long COVID clinic, and it's also the staff are working very hard. And then the last key success factor is a sort of learning health system ethos, where all the time the clinic is capturing data on its own performance and leads in to learning and change. So we took a step back, we stopped the Quality Improvement Collaborative, and we asked a slightly philosophical question, I suppose. What is quality in a long COVID clinic? How do we define it? And some of you may have seen some of those papers that we're doing a series for the British Medical Journal, really addressing that question. What is good long COVID care, but also what's good care for, say, breathing problems, what's good care for brain fog, et cetera, et cetera. So some of those are published, some of them are in the pipeline. I was also really interested in this question of why did this QIC produce more conflict than agreement on quality standards, because I think this is a kind of philosophical thing about the conflicts around long COVID in the literature, both the lay literature and the professional literature. And we've heard a bit about that this morning, people whose employers will not accept that this is a real illness, for example. But I also wanted to look at how long COVID teams actually worked towards a quality service in different localities. And so what we did was we interviewed clinic staff, we met with our patient advisory group, and I started attending the online multidisciplinary team meetings. And so far I've seen about 200 patients discussed, and I'm visiting those clinics. I'm going around the country and I'm sitting in on consultations, obviously subject to patient consent, and seeing what staff are doing and interviewing them on the job. So this has led to some very interesting new findings about why it's so difficult to, if you like, implement research findings. And the first reason is, as I've said, these clinics have very different histories. And if you've got a history of, for example, being a respiratory clinic, that creates a path dependency. Everyone, for example, gets a kind of standard set of lung function tests because it's a chest clinic, really. And that also restricts the scope, and it restricts what kind of pathways there are for getting into the clinic, and also where you can go if you're seen in that clinic. There is a huge diversity in the caseload seen by the clinics. And in some long COVID clinics, it's completely different from others. There are a lot of material constraints. Actually, physically visiting these clinics makes you realize that very often what gets done is constrained, for example, by the number of consulting rooms there are, the size of the waiting room, whether or not the clinic happens in person. Some of these clinics are completely virtual. The amount of physical space, some of them are on the top floor of a tower block. Some of them are a bit more accessible. Staffing, different clinics have different staff, and it's all very well to say test X must be done, but if they haven't got a member of staff who's properly trained to do that, or if a member of staff has got something more important to do or seen as greater priority, you're not going to get them doing whatever it is you want them to change and do. But one of the most interesting things that I've found in my ethnographic visits to the clinics is that each multidisciplinary team has a different, what I call an evolving working knowledge. Most people on this call will already know that when you go to a long COVID clinic, you don't just be seen by a doctor, you get seen by a physiotherapist, perhaps a psychologist. In one clinic, there's a sports and exercise specialist, occupational therapist, etc., etc. And different members of the team have different individual knowledge, but one of the most important things you need to know as a member of an MDT is what the other members know and what they can do. And so when you see a patient who's got a particular set of challenges, you can say, oh yeah, well, you need to see so-and-so. And that working knowledge among the team of who chips in at which point is shared among the team, and it evolves as the team gains more experience. And some of these teams have been going for 3 years now, and they are highly experienced, and they've got very rich working knowledge. Of course, if somebody leaves and a new person comes in to work in that clinic, they've got to pick up that working knowledge. So staff changes are actually quite a problem. So all that adds up to quality in a long COVID clinic being, at least to some extent, what I've called a local and collaborative achievement, which is very specific to that clinic, rather than a generic and context-free standard. And what that means is that the implementation of so-called evidence-based practice is particularly challenging in long COVID clinics compared to, say, a diabetes clinic, which is where I started off in life. So in summary, implementing evidence in long COVID clinics is difficult because of multiple complexities. And I am increasingly of the view that one size doesn't fit all. These clinics are never going to look the same in every setting because of the path dependencies and the very kind of local emergence that characterizes those clinics. So I think I have now finished. I will hand back to the chair.
Thank you very much, Trish. That was really, really helpful and really interesting. I'm Susanna Thompson. I am a GP and co-chair of today's session. I am a doctor with long COVID who has been on my long COVID journey for 3 years. And as you say, been through a respiratory clinic initially for long COVID when I have no respiratory issues with my long COVID. So it's all really interesting seeing how that all plays in together. I'm also part of Long COVID SOS, which is an advocacy charity with goals around recognition, research, rehab, and trying to help people recover and live the best lives they can. Thank you so much for your and we look forward to questions in a minute. We're just going to hear from Fiona and then we'll have questions coming forward. Thank you. So I'd like to introduce Dr. Fiona Glen, who is leading a session on how clinical research makes it into NICE guidelines. So leading on from the presentation we've just heard, how that gets then implemented into the guidance. Fiona is the Programme Director of the Centre for Guidelines at NICE, with oversight of the development of evidence-based guidance for health, public health and social sectors. She started her career in academia and moved into public sector, working at the Office for National Statistics, and then onto Equality and Human Rights Commission, where she was Director of Research and Public Policy. Thank you very much. I'll hand over to you now.
Thank you. I'll just share my screen. Okay, thank you very much for the opportunity to talk today. And it's obviously really great to come on after Trish, someone that we greatly admire at NICE. More broadly, of course, it's great to talk about a topic that we've worked with you and the audience.
Fiona.
Oh, brilliant, thanks. With the audience for quite a long time. So hopefully this will be a helpful segue after Trish's talk. So I'm sure most of you know about NICE, and I'm hoping that within the audience, we've worked in NICE with a lot of you over the last few years on long COVID. You may not be familiar with the process around guidelines, and you may actually know more about NICE through some of the work that we do in the media, so some of the drugs that we approve for the NHS. But basically, NICE is an NHS organisation that's been running for quite a long time now for a public sector organisation. We've been going for just over 20 years. And our remit over that period hasn't particularly changed. We very much are about putting advice and guidance into the health and care system. So taking evidence and translating that into good practice for practitioners and people with lived experience. We also deliver education and training, and this is around therapeutics and medicines, and we provide an advisory service as well to devolved administrations and pharma companies. My role at NICE, as the person who introduced the session said, is very much in guidelines. And so over the 20 years, we've produced an awful lot of different types of evidence products, and guidelines is a big part of that. And at NICE, we have about 350 guidelines that cover a breadth of clinical, public health and social care topics. And those 350 guidelines need to be checked regularly to see if they still take into account the most recent research and evidence, and that the recommendations are still valid and appropriate for the systems that they serve. Now, I was asked to talk about how research makes it into NICE guidelines. And in doing that, I really needed to talk about the guideline process, because that's quite important in a way of showing what we do. But I think it's also important to recognise that actually NICE doesn't have a direct remit in saying what research should be carried out and also what research should be funded. That very much is done at a community level, and my experience of working in long COVID over the last few years very much has been that actually it is as a community, the people around this virtual table today, all our knowledge together has influenced the way that research has been commissioned and also the type of research that's been carried out. We do, however, play a small but vital role in really reviewing the research landscape at a particular time, and the guideline process allows us to do this. So the diagram in front of you at the moment is just a crude version of how we produce guidelines at NICE. So we are referred a particular topic by our DHSC ministers. This comes into the system, and at that point we will actually go away and look at the breadth of evidence that's out there at the time. So we'll carry out literature searches, we'll talk to experts in the field, and that will allow us to form a scope and allow us to understand what the key questions are that we need to answer in the specific guideline. In carrying out this broad literature search and broad evidence review, we'll bring that information in together and we'll review it. We'll look at where there's gaps, we'll look at the quality of that information, and then we'll present that to a committee of experts. And these experts are practitioners, academics, people with lived experience, who are brought together and asked to review this literature, to look at the quality of it, and to think about what evidence-based recommendations they would like to make to the system that this guideline is covering. Now, that's where the key process is in terms of research, because what we will get out of that process are a number of recommendations for practice within the system. But more broadly, at the end of that process, what we will have seen is what information is out there, what good quality evidence is there, and we'll have quite a clear map of the landscape. And what we ask of our committees is, once they've carried out this process, is to also think about where the key gaps are. So areas where they didn't have information, or areas where that information was particularly weak or poor quality. And from that, we'll create a series of research recommendations. Now, what these research recommendations will do is they'll provide a format that we will send to NIHR to allow them to understand where there are key gaps in the current evidence landscape and areas that they may want to carry out research calls or funding calls in the future to fill those gaps. What we'll do on the back of that is we'll wait for new research to come out, and then we will update the relevant sections of the guideline. And this is a continuous circle where we're looking for evidence, writing new recommendations, putting out research recommendations, and waiting for new research to help us improve the guideline going forward. So this system was a system in place when we started to work on long COVID. And if you can cast your minds back to the end of 2020, we were referred a guideline and work around the case definition by the current CMO. And he asked us to think about, how do you define long COVID and how do you treat and manage it? And at that point, we very much worked with you in the community, those who had started to do early research, such as Trish, people that were starting to collect information through different apps. And this area of sort of new territory, we brought together very quickly and carried out an evidence review and a landscape map. And this information not only helped support the guideline, but it went forward to the first round of NIHR funding research, which you see on the left-hand side. Subsequent work since the guideline has been published and updated has also led to the second round of long COVID funding that occurred too. And I'll talk a little bit about the research recommendations that came out of that later on. The guideline covers really the pathway of care for long COVID. And this diagram is just put in to show the pathway that we focus on and the areas that we have recommendations on. And that's important when you start to think about how we manage that content over time. So if you think at the end of 2020, this was emerging condition, we were aware that what we were doing was relatively new and that we needed to keep on top of the literature and we needed to really monitor this condition closely because of course it was new, forming, and we weren't sure if our guideline covered every aspect of care, and we certainly knew that new evidence would emerge over time. And indeed, this was definitely the case. What you see here are our team looking at literature relevant to the guidelines, so relevant to that pathway over time. And what we saw was this explosion of information coming through. These are relevant pieces of literature that land on our desk, that we search for and actively look for, and that we have to review to see if there's any content that could change or drastically change the guideline. But the irony, of course, with that is that actually that evidence hasn't changed some of the recommendations so far. And that's for a couple of reasons. Often the evidence is around symptoms. We see an awful lot of new literature around symptoms that work has been carried out on. We have recommendations around that. That isn't an area that we feel is an area that needs to change within the guideline at this time, unless there's new radically changing information coming through. But we also notice that there's very little randomized control trial data out there around new drugs that can treat or manage long COVID. Now, that's not to say that we just use RCTs. We definitely look across the breadth and the broad church of literature out there. We have to do that for long COVID. But it is important to recognize that for those new key drug treatments coming through, there's very little work being done on new drugs at the moment in long COVID. As part of our work, we maintain a watching brief over all the new trials. And this is a slide that just tries to highlight the new trials that we watch, but that's not to say that we don't look at other information as well. And we have constant searches going on behind the scenes looking at new emerging literature. Recognizing that we needed to be more fleet of foot in our work than we can be on other guidelines. We carry out regular weekly reviews of the literature, and we assimilate this into a quarterly research bulletin that we take to our committee, and we ask them if there's any new game-changing information in there that can change the recommendations that we have in place. We updated the guideline in 2021, and we have a watching brief on both of these, all these new trials coming out, and also our quarterly research bulletins as well. Of course, I talked about the importance of the cycle of updating within the guideline. And our long COVID guideline has a number of key research recommendations that are fed directly through to NIHR and others. And as you saw, these research recommendations have driven rounds of funding to look at new research. I'm not going to go through these in depth, and you'll see why. That's because I have 4 slides of key research recommendations. And I highlight this just to show that I think we are all aware that still this condition is still relatively unknown, and that we need to carry out an awful lot more research to make sure that we are really supporting the frontline and practitioners to make sure that they are giving the best care. So I'll pause there and happy to take any more questions. Thank you.
Yep, thank you to Fiona and Trish for those great talks. We've had quite a lot of questions coming through. One of the questions was specifically to Professor Greenhalgh. So how much has the lack of coherent knowledge about long COVID driven the possible lack of coherence in long COVID services, i.e. the more that is known in clinical practice, the more that can be standardized?
Absolutely. I think the questioner nails it. Do you know, it's really interesting. I'm listening to Fiona's presentation, and we know each other from early in the pandemic and probably before. I think these talks might have worked better the other way round, in the sense that Fiona was giving a great talk about how NICE works to get the research evidence and put it into guidelines. And what I'm saying is, yeah, except that in long COVID clinics, that isn't working very well. And I am absolutely fascinated at a philosophical level as to why this is. You know, I'm excited about it. The more clinics I visit, the more the penny drops in. Oh yeah, right. So that's why you can't do that. And I think it's not that there's no evidence. It's the opposite. There's so much evidence. There's loads of evidence. There's more evidence on this condition than on any other condition I've ever worked in and with. It's that the condition itself is so complex. The condition manifests itself in so many different ways. The patients that I have met in the clinics and whose cases I've sat in on discussions of, and as I say, that now runs into the hundreds. Many of those patients have pre-existing conditions, comorbidities, complexities, unusual things. They are absolutely unique in who they are, what they were like when they got COVID, and how COVID then led to things happening in their body and perhaps in their mind or whatever, that's completely unique. Now, I trained as a diabetologist, and it's completely different. You may maybe have 2 or 3 or 4 different ideal types of someone with diabetes. You have the young person who's got type 1 diabetes, they're perfectly fit and healthy, they want to run a marathon, that kind of thing. And then you've got someone else. You can just list them on the fingers of one hand. And so running a diabetes clinic is dead easy compared to running a long COVID clinic. When the disease itself affects every organ in the body, it, as we all know, causes what someone called a thrombotic endothelitis. Well, I can tell you, you've got endothelia everywhere on the inside of all your organs and blood vessels and all the rest of it. So the manifestations of long COVID are legion. So one of the problems with the research is if you do a trial, what are your inclusion criteria for that trial? Who's going to be included in that trial? And then you have this paper that says drug blah works in long COVID, and then you've got to go back and say, hang on a minute, who are we talking about here? Are we talking about, Mrs. Patel that I saw last week, who's also got this, this, and this? And maybe we're not. So, by the way, I made up that name just in case anyone thinks I'm breaching confidentiality. It's the first name that came to me. So that's one of the things. And I think, again, philosophically, you've got this kind of law of repeated deconstruction, because everybody with long COVID is different, and therefore you cannot take a representative sample of the population. That's one of the problems. But the other problem is that because of the way long COVID research has been set up, many of the clinics are measuring all kinds of things. And so I sat next to a poor bloke. I mean, he had long COVID. That was why I was there. And he's got this stack of questionnaires to fill out. He's got some mental health questionnaire. He's got a fatigue questionnaire. He's got a general long COVID questionnaire. He's got, what they are. Many of you have filled them out. And why are they using all those surveys? Why are they using those particular instruments? And one of the things we did in the QIC, one of the first things we did was to say, let's standardize the use of which instrument we use to monitor patients' progress. And we tried that, and everyone agreed. We got agreement, we got sign off after several meetings. And then you go to the clinics and they're using a completely different set. And so you say, well, why? And one clinic says, well, actually, in order for a patient to be referred into the mental health support team, they have to have filled out these 2 surveys, because these 2 instruments, because that is your ticket to get into the mental health support team in that locality. So the fact that in a national QIC, we wanted a different instrument to measure people's mental reactions to long COVID doesn't matter. So then we say, oh, well, let's give them everything. Let's give them those 2 that the mental health service want. Let's give them our one that we agreed nationally. And you all know the problem with that is when you've got brain fog, filling out one of these things is bad enough, but filling out a dozen, literally, is exhausting, and I actually think rather dehumanizing. So I think one of the problems, come back to the questioner, is it's not because the clinics are deliberately being lazy. It is because of the complexity of the way long COVID manifests, the diversity, but also because of the way that clinic sits in the local ecosystem. And as you can imagine, I've already written, I think, 3 or 4 papers recommending a standardized way of organizing long COVID services. I ain't going to do any more of those. What I'm interested in is explaining the diversity of the services we've got in terms of disease factors, patient factors, local healthcare ecosystem factors, etc., etc., but also arguing that it's okay to have that variation. It's not unwarranted variation, as the value-based healthcare people call it. Does that make sense? Okay, I'll shut up because that was a very long answer. It's just one that I'm quite excited about.
You can see the passion and fully respect it as someone living with long COVID, and greatly appreciate that that passion is out there. There's really a follow-up question for you, Professor Greenhalgh, that goes with it. Given there are so many different elements to the long COVID diagnosis, that there are so many different branches of the symptoms, the way it affects someone's life, and so many different ways it's tested and treated, would there be a benefit of changing the way the NICE guidelines portrays? So instead it's a best practice, rather than relying on all the randomized controlled trials and things, it's best practice taking into account all the different variations. So it would be quite a different idea. Or what would your thoughts be on, and would that help having the power of NICE behind it to say, these are the changes? And then I'll ask Fiona Glen as well. But first of all, Professor Greenhalgh, what do you think?
I think this is for Fiona, actually. It's all about NICE.
So, what do you think, Fiona?
Well, I think some people would argue that our guideline is aspirational and best practice. And I think it's also important to recognise that when we first wrote that guideline, there were absolutely no RCTs out there. We very much drew on consensus opinion, practice at the front line, patient-led thought, and that brought together a real broad church of information. And actually, when I look at the guideline now, I'm not really sure it relies on many RCTs now, actually. What it does do is it brings together that broad church of opinion on how to treat it. And, you know, depending on who you talk to, some people like the guideline, but others really don't. They don't find it too helpful. They find it holistic. They find there's too much breadth for choice in how to treat long COVID. And I am conscious that there are different ways to write a guideline around long COVID. We chose this approach based on expert opinion and what our committee felt was the best approach at the time. But it certainly is a document that's worthy of checking regularly to still see if it supports the system in how to treat long COVID.
Very quickly, when you talk about regularly checking, obviously the guidance itself was last updated in November 21. And from my point of view, reading all the research I see coming out, it seems an incredibly long time to have gone, you know, getting on for 2 years without an update. It'd be interesting to know why and when the update's going to come and how that would fit. Yeah,
and this is one of the problems that we've had. We check every week about new evidence. And one of the issues around this is that our recommendations are quite broad. They take into account a lot of information. And we check regularly to see if the information coming through the new evidence changes any of those recommendations. And I suspected this would be a question. And so what I have tailored on at the end of all my slides are the most recent quarterly survey. So we take all the information from the last quarter that we've checked regularly. We, at that point, don't think there's any reactions that we need to take in the guideline, but we double check with our committee of experts. And that information is constantly assessed. So while you don't see a change in the recommendations, it's not to say that there's a huge engine and machine going on underneath checking whether there's new evidence. And the reason that I talked about in the RCTs is actually they're the very clear, you know, we know that they've been logged, that they're working away behind the scenes. We know when their information is going to publish. And so often these areas are going to be game changing for the guideline. And it's those that I put in a slide so that you know. But to reassure you, there is lots of work going on. And the fact that we haven't updated the guideline is that the recommendations are still live and still relevant according to new evidence that's come out.
I'd be really interested to know, Professor Greenhalgh, do you think that it's still as up to date as it could be, or do you think there are changes that would be important around best practice?
I think that I mean, there's full disclosure. I think I was involved in developing this guideline, or I was involved in the what's I think called the oversight group. But anyway, I had a role. I can't quite remember what my role was. So I'm not a dispassionate critic of this. I'm with the band, so to speak. I remember some very heated discussions, people feeling very strongly about things, people not agreeing with each other. And looking back, I can see that this was inherent to the complexity of long COVID. Now, what that means is not only are we never going to get a guideline for long COVID that is 100% up to date, which does everything that everyone wants from it, but also perhaps we should engage a bit more with the uncertainty and the doubt that is going to characterize this condition forever. In other words, this idea that if we could only fund more and more randomized controlled trials, if we could only have a guideline development group that worked harder and faster, et cetera, then we would get this perfect guideline that would then, we could all go along to the GP or to the consultant and say, right, I need this because it says it in the guideline. That is never going to happen. It's never going to happen because of all the things I've talked about and all the things other people have talked about. But what I do think is that may not matter, or at least it may not completely hold the ship below the waterline, so long as we treat the guideline with the disrespect that it deserves, if you see what I mean. In other words, and actually Fiona said this at the beginning, and I nearly said it myself, and then I thought I'm going to hand over to her because it's her guideline, that all nice guidelines, and I've got 2 PhD students looking at this very topic, all nice guidelines are used to some extent by practitioners, but not to their full extent. Because if we were all following every word of every guideline, apparently it would take 150 years to treat every patient or something. So guidelines are always dipped into, looked at, yeah, but I'm going to ignore the guideline on this occasion. But I think that's going to be particularly the case with long COVID. The other thing is, as we know, comorbidity or pre-existing illness is a feature, not a bug in someone with long COVID. And it may well be that what we need to do is, for example, apply the asthma guideline and make sure that that person's asthma, which was exacerbated when they got long COVID, but make sure their asthma is optimally treated according to the asthma guideline. Make sure their diabetes is optimally treated, make sure their polypharmacy is addressed, and so on and so forth. So I think we need to treat each patient as an individual. I'm very keen on holistic care. And I do think it's a good idea for a long COVID guideline to exist, but we need to make sure that, this isn't the 10 commandments. This is something that we need to have a little bit of a kind of a conflictual relationship with, shall we say.
Thank you very much, and thank you both for your insights on that. I'm sure this discussion will continue into the panel discussion. We'll take a 10-minute break now.
Hi, I'm Zane, the CEO and co-founder of Eureka Health. Eureka is a website for patients to share their experiences trying different treatments to help everyone learn what's working and what's not. Our goal is to enable you, whether you're a patient, a clinician, a researcher, to find treatments that are most likely to work for specific types of long COVID. Now, we all appreciate the need for more research into more treatments, but clinical trials can be slow and expensive. Meanwhile, patients are often left navigating one-off anecdotes in online patient communities like Reddit or Facebook. And so that's where there's a significant data gap and where Eureka steps in. My personal connection to this is my mom. She was diagnosed with a chronic neurological condition about 5 years ago. Doctors soon ran out of treatment options, so we found ourselves turning to online patient communities. And although there's no cure, we did find a mix of treatments that helped her manage her symptoms, preserving her quality of life. Eureka is aiming to streamline this process. We collate data from these real-world experiences to offer better, faster insights. And we're not just helping patients. We're also giving researchers and clinicians more immediate data on what treatments are working. Today, we have over 23,000 treatment reports spanning across nearly 250 different treatments. And based on this patient-reported data, we're able to match individuals with treatments most likely to benefit their specific symptoms. So our mission is to bridge that data gap between patient anecdotes and clinical trials, and to foster a stronger link between patients and research. We're amplifying the patient voice and accelerating evidence generation. So if this resonates with you, I invite you to visit us at eurekahealth.com. Together, we can speed up the journey to understanding and managing long COVID, ME/CFS, POTS, and many other chronic diseases. Thanks to Long COVID Support for having us here.